Hello and welcome back again to SciComm 2020. So with that, it is my honor and privilege to introduce our third SciComm 2020 keynote speaker, Dr. Uché Blackstock. Dr. Blackstock is an urgent care physician and a thought leader and a much sought after speaker on health inequalities and racism in healthcare. We're incredibly lucky to have her here with us this evening. I just learned that she's turning down all speaker invitations until 2021, so I'm thrilled to have her. She's the founder and CEO of Advancing Health Equity, an organization that partners with healthcare and healthcare-related organizations to address the critical factors contributing to health inequality. And they do this through talks, workshops, and consulting services. In 2019, Dr. Blackstock was recognized by Forbes magazine as one of the 10 diversity and inclusion trailblazers that you need to be familiar with. And her writing has been featured in the Chicago Tribune and sat news for the Boston Globe. Since the pandemic began, she's been interviewed by numerous news outlets and organizations, all seeking to gain her wisdom and knowledge regarding COVID-19's impact on minoritized groups. Dr. Blackstock was formerly an associate professor in the Department of Emergency Medicine and a faculty director for recruitment, retention, and inclusion in the Office of Diversity Affairs at NYU School of Medicine. She left NYU School of Medicine in December of 2019 after almost 10 years on faculty, and now she's focusing mostly on advancing health equity. Dr. Blackstock received both her undergraduate and medical degrees from Harvard University, and we are absolutely honored to have her here with us today. And with that, I will turn it over to Dr. Blackstock.
Thank you so much. I am very excited to be here. So I'm Uché Blackstock. I go by pronouns she, her, and hers, and I will be speaking to you about mobilizing for health equity. I usually start my talks with a land acknowledgement. Unfortunately, you can't be in person, but I am speaking to you from Brooklyn, New York, which is actually my hometown. And in countries such as New Zealand, Australia, Canada, and among tribal nations in the US, it is commonplace, even policy, to open events and gatherings such as these by acknowledging the traditional indigenous inhabitants of that land. Acknowledgement is a simple, powerful way of showing respect and a step toward correcting the stories and practices that erase indigenous people's history and culture and moves us toward inviting and honoring the truth. So I would like to acknowledge that I am standing on the ancestral lands of the Lenape people. I'd like to acknowledge the lands of the indigenous people wherever you are tuning in from, and we pay our respects to their elders, both past and present. I'd like to tell you a little bit about me. I am a second-generation physician. This woman in the picture is my mother, who's the original Dr. Blackstock, and in her arms are my twin sister and me. And I'm sharing this story with you just to show you or tell you a little bit about my journey and my inspirations. My mother grew up in very different circumstances than I did, only about 15 minutes where I am right now. And she grew up in poverty here in Brooklyn, New York. She was the first person in her family to go to college, the first person to go to medical school because she had a chemistry professor who encouraged her to apply. And after she got into medical school, she ended up matriculating at Harvard Medical School. And after medical school, she actually came back to her community in Brooklyn, New York, and she practiced here for many years. And so I learned from my mom, always giving back to our community is very important. This is my twin sister with my dad at our medical school graduation. I'm on the left, my twin is on the right. Unfortunately, our mother could not be there because when we were sophomores in college, she was diagnosed and passed away from acute myelogenous leukemia. But our goal is just to keep her legacy alive by the work that we do to address racial health inequities. I wrote a piece about my mother in the Chicago Tribune last year, really speaking to the importance of a diverse healthcare workforce, because we know that's one of the solutions to addressing racial health inequities. And that's my mom and my sister and I sitting on her many years ago. And I mentioned, or it was mentioned in the intro, that I left my position at NYU. And one of the reasons why I did leave to start my company is because often organizations, even healthcare organizations that deliver care, the culture can be sometimes hostile and inequitable to people who look like me, to Black and brown people. And so I left my position because I knew that I could be more impactful doing work for my organization, advancing health equity, than working internally. And so I also start out my talks with talking about mindsets. Mindsets it's your belief in your ability to grow and improve. And so a fixed mindset is assuming you are a fully formed human being. So if I say, I suck at basketball, or I'm really great at basketball, that's a fixed mindset. But if I say, with effort, time, and feedback, I think I can get better, that's a growth mindset. And you'll be hearing information today that may be new to you, and I want you to have a growth mindset when hearing that information and absorbing it and thinking about next steps. And I also have a discomfort disclaimer. Some of the information we'll be talking about today may make some people uncomfortable, and I want you to sit with that discomfort, thinking about why do you feel that way, and knowing that that discomfort just means that we need to have conversations. And these conversations that we'll be talking about today have to do with health, life, and death. And so it's very important, and I hope that you all stay engaged with me. And so these are the objectives for the presentation today. I have a lot of content for you that I hope that we can get through, but I'm going to talk about the historical and current day impact of racism on health equity. I'm going to introduce you to a term called structural competency to better understand how to address racial health inequities, and then we'll talk about some strategies. And so why are we here today? We are at an unprecedented time in our country. We're in the midst of a pandemic that has exposed profound racial health inequities. And we also, in the last few months, have had the killings of Black Americans by civilian vigilantes and by police. And we're having conversations now that we have needed to have for a very long time. And we also see that, as I mentioned, there are profound health inequities, but there are also other significant inequities between when you compare Black and other people of color to white counterparts at every age and income level: education, income, police brutality, and rates of incarceration. And I'm going to talk to you a little bit about why this happens. And so we're going to focus a little bit on health. And these are some current health statistics that some of you may or may not be familiar with. Black babies have the lowest birth weight, highest infant mortality. Black women have the highest maternal mortality rate. That may be something that you've heard about in the news over the last few years. And Black men have the shortest life expectancy. I want to show you this graph, and I want to use it to explain to you how far and how not far we've come. In the 1850s, 15 years before the end of slavery, many babies did not live to their first birthday. As you can see, the infant mortality rate was quite high for both Black and white babies. The rate for Black babies was about 1.5 times that for white babies. And many babies did not live to their first year of life. It was the point where parents did not name their children until they were 1 year old. But over time, with improved hygiene, sanitation, living conditions, infant mortality rates for all babies improved. By the 1960s, though, the US was dead last among all industrialized countries in terms of infant mortality. And just 2 years ago, the rates, although they have improved significantly, the Black rate compared to the white rate has increased. It's more than twice as likely for a Black baby to die within their first year of life compared to a white baby. And so that is a wider disparity than we had 15 years before the end of slavery. As for maternal mortality, we're now one of 13 countries with worse maternal mortality rates now than 25 years ago. You've probably heard this statistic that Black women are 3 to 4 times more likely than white women to die from pregnancy-related complications. And this rate is even higher than countries like Mexico, where half the population lives in poverty. Another point that I want to emphasize is that many of these differences, it's not just socioeconomic, it actually persists across socioeconomic status, as well as professional and educational attainment of the mother. And so I want to just explain that, when you are looking at these issues, we know that there's something deeper going on, not just socioeconomics. And here we are in the midst of a pandemic, as I mentioned in the opening, that has revealed these profound inequities. We know that there are Black communities being disproportionately impacted by COVID-19. Our Indigenous communities are being also significantly affected. And this was before the latest surge in cases in the South and West part of the country. Navajo Nation at one point in May had the most cases, even compared to per capita, compared to any state in the country. And of course, our Latino communities have also been disproportionately impacted as well. And so what we've seen is when there've been recent studies that have shown there are differences in testing availability in racialized minority communities. We are seeing difference in diagnosing in infection rates and cases, and who is hospitalized and who dies from COVID-19. And so I want to give you some definitions that we're going to work with. One is health equity. Health equity, you probably have heard it before I introduced my talk with it. It's the opportunity for everyone to attain their highest health potential. And as a clinician, as a physician, that's what I want for all of my patients. And I think that's what everyone in healthcare would want for their patients. Health inequities are differences in health conditions that are influenced by social, economic, and environmental disadvantage. And what I want to emphasize about this definition is that these are people-made, human-made disadvantages. These are due to social and economic policies, and I'll get more into that. Health disparities are differences in the presence of disease or health outcomes between population groups. And so often disparities and inequities are often used interchangeably. I've been guilty of that. The health inequity is, for example, when I tell you that Black women are 3 to 4 times more likely to die around pregnancy than white women. That's a health inequity because there's no biological basis for that. That happens because of social economic disadvantage. But if I tell you that male babies weigh more than female babies, that's a disparity. There is a biological genetic basis for that. And so going even forward, thinking about equality and equity, often these terms are used interchangeably. Equality is essentially giving every person the same thing. So say you have 3 people watching a baseball game, they're all on different levels. And they have a fence in front of them. That fence represents a structural barrier. You can even think of it as racism or sexism. And the person in blue can easily see over the fence with one box. However, the one in red has to tiptoe and the one in yellow can barely see. But what equity is giving each person what they need to reach their fullest potential, or in terms of the baseball game, each person what they need to be able to watch the game. And ideally, we wouldn't even have a fence there, right? A fence is when all of those structural barriers come down and everyone can watch the game. And that's what liberation is. And that's what I would hope for my great-great-great-grandchildren. And so I want to share this pyramid with you. And the significance of this pyramid from the CDC is that socioeconomic factors have the largest impact on health outcomes. So factors like poverty, housing, inequality in education have a larger impact than the prescriptions that I give to my patients, how much I counsel them on how well to eat. Of course, what I do is important, and what other clinicians do is important, because what I do can actually perpetuate underlying structural inequities. But keep in mind, the largest impacts are socioeconomic factors on health. And when we look even more deeply on a more granular level, those socioeconomic factors include education, as I mentioned, the type of job you have, your income, how safe your community is, okay? Physical environment counts for about 10%. These are the social determinants of health. These are the factors that influence the health of people and communities. And as you can see, depends on a lot of different factors, but socioeconomic factors really determine how healthy a community is. And so why do these racial health inequities exist? They exist because there are differences in the quality of care received in the healthcare system. Institutions in minoritized communities are more likely to have fewer resources, more untrained healthcare professionals, and we see this in terms of the outcomes, of poorer outcomes. There are differences in access to healthcare. We know that Black and Brown communities are more likely to be uninsured or underinsured. And also differences in life opportunities, exposures, and external stresses that actually influence health. And so I wanted to share this map with you. This is of COVID-19 cases in the midst of the pandemic here in New York City, but I wanted to share with you that there were differences even down to the zip code. So we know that there are inequities in terms of health down to the neighborhood level, depending on where you work, live, and play, that influences your likelihood of being infected and even dying from COVID-19. And so I want to ask all of you, when we think of race, how do you define race? And so I want to give you an opportunity to answer this question. So you can text UCHE BLACKSTO 398 to 22333. And I want to find out from you, how is race defined? Is it defined by skin color, hair texture, eye shape, geographical ancestry, or all of the above? All right, so it looks like most people are saying geographical ancestry. Some people are saying all of the above. Looks like those two are coming in for the tie. All right, so looks like more all of the above. Geographical ancestry, all right. Anyone else want to answer? Okay, so it looks like all of the above is winning. Thank you, everyone, for contributing. Okay, so all of the above. So race is a social construct that I want to make sure to emphasize to everyone that it is nothing biological about it, and it's used to categorize human beings defined by all of these markers. So the answer was all of the above: skin color, hair texture, eye shape, and geographical ancestry. So that's what race is. This is just one definition of racism. It's a system, and I want to make sure that when you leave this talk today that you understand that this is not about interpersonal, someone being mean to someone because of who they are. This is about a system of social structures that provide access, safety, resources, and structural power to those with racial privilege and denies it to those without. And the system, as I will show you, can actually be sanctioned by the state and produce and reproduce race-based inequality. And so this is a racism iceberg that I want to share with you that kind of emphasizes the point that I made on the previous slide. A lot of times when people think about racism, they're like, oh, it's a hate crime or someone being rude to someone because of their race. But really what racism is and what supports it is it's like a systemic institutional racism. So how laws and policies and practices support mass incarceration, school segregation, residential segregation, and even mortgage redlining. And that's what we typically don't see because it's less obvious to see those than to see someone being mean to somebody or someone harming someone because of who they are. So I want to give you an example. This is Frederick Delano Roosevelt, former president. And between 1933 and 1939, he essentially developed the New Deal. And the New Deal was a series of programs, public works, and financial reforms. The point of it and the purpose of it was to help Americans recover from the Great Depression. But the most important role of the New Deal was the development of the FHA, the Federal Housing Administration. And it subsidized the mass production of entire subdivisions. It basically was responsible for the development of what we now know of as the suburbs. But it did so with the requirement that no homes be sold to Black Americans, and that every home in these subdivisions had a clause in the deed that prohibited resale to Black Americans. Okay, and so what happens when you can't own property? If we know that property taxes go to funds public education, we know that the schools will not receive property taxes or don't receive property taxes. If we know that no one wants to buy property in a certain area, then how businesses are not interested in coming to that area. And so the New Deal was one of those federally mandated policies by our own government that actually discriminated against Black Americans and is one of the factors responsible for the racial wealth gap that we see today. And then another policy that may surprise you is the GI Bill. So the GI Bill was designed to support returning World War II veterans. And many of us know of the GI Bill because it gave educational opportunities to veterans. They received financial aid and scholarships. But another part of the GI Bill was to help support returning veterans obtain low interest mortgages. The problem was that all these mortgages were not given to Black returning veterans who were looking for to buy homes in Black neighborhoods, unfortunately. And so they were not able to benefit from these mortgages because they were told they could not buy homes in those neighborhoods. So again, the New Deal, the GI Bill, are contributing to what we see today, this really profound racial wealth gap. And I know you're probably wondering, why am I speaking about racial wealth, about this wealth gap? Because it all influences health. And so this is what we see, this profound gap where Black and Latino median household wealth is significantly lower than that of white households. And that's not because Black and Latino families haven't worked hard. That's because there have been policies designed by our own government that have discriminated against certain groups over others. And so I want to introduce to you this idea of structural competency. It's this idea that not only do the social determinants of health that I mentioned earlier influence health outcomes, leading to health disparities. So if you have areas where there is inadequate housing, poor public transportation, low job opportunities, poor education, you're going to see health disparities, health inequities. But it's also this idea that more upstream, there are social structures like social and economic policies, the kind of economic system that we live in, which is a capitalist system, social hierarchies like systemic racism actually influence the social determinants of health, which more downstream influence health disparities. And so I want you all to think more broadly about how social structures, institutions like healthcare, the legal system, educational system, all influence the health of communities. And so from this, I want you to understand that often we hear about race being a risk factor for disease. I've read in textbooks, oh, being Black or Latino is a risk factor for developing diabetes or high blood pressure. And we know that race is not biologic, right? It's a social construct. But what is that racism is a system that creates advantages and disadvantages. And those disadvantages sometimes we see actually manifest themselves as disease. So when you are in settings where you don't have enough income to purchase property, where you don't have access to healthy food, we see that manifest as disease and inequities. And so I want to share with you all a little bit, it's not an exhaustive timeline. I want to give you an idea of the relationship that communities of color, specifically Black communities, have had with the healthcare system and why we're in the situation we're in now. And so I'm going to give you, this is like a very long, very broad overview, but we're going to start from slavery. So during slavery, there was a gynecologist. His name is J. Marion Sims. He's in the right of this picture. He is actually considered the father of modern gynecology. He was the first president of the American Medical Association, which is the largest association of physicians in the country. But he also made these discoveries. He developed the vaginal speculum, which people who have gynecologic exams have used on them. And that's a very common tool used during a gynecologic exam. He also developed a procedure to fix a disorder called a vesicovaginal fistula. It's essentially a tear that happens in the gynecologic organs when people have during childbirth. So these are really amazing, profound discoveries that he made, but he made them by experimenting on women who were enslaved. And so the woman who's sitting on the table, who's kneeling on the table, her name is Anarcha. She was a woman who was enslaved, and he performed up to 30 of these painful procedures on her. At the time, local anesthetic had been developed, but he actually did not even use it on these women. So he performed on probably about 14 women, these procedures, which ended up really contributing to medicine and to healthcare. But the conflict is that he did so on women who could not give informed consent, and did so without using any local anesthetic. So you can imagine, as a physician, as someone who's well respected in their community, doing this, is obviously very horrific. This is Henrietta Lacks. So we're moving forward in time. So even after slavery, there was significant inequality in terms of who had access to healthcare and who didn't. Henrietta Lacks was only 31 years old when she died. Some of you may have heard of the book about her. It's called The Immortal Henrietta Lacks by Rebecca Skloot. And essentially, she presented to Johns Hopkins Hospital with metastatic cervical cancer, so very advanced cervical cancer. And her cancer cells were taken away from her, and they were sold to companies. And companies have made billions of dollars using her cells for research. I used her cells when I was in medical school in my first year histology class without even knowing it. Her cells are called HeLa cells, and they've been used to make numerous discoveries. They're even being used to in research and development of the coronavirus vaccine as we speak. But the sad part is that she was never told that her cells were being taken from her. She ended up dying a few months later. Her families were never told, and she never gave informed consent. Okay, she never said, yes, you can use my cells for this. So again, a betrayal of a patient and her family by the healthcare establishment, and an exploitation as well. And then as time goes along, we had another study called the Tuskegee Syphilis Study of untreated syphilis in the male Negro. Some of you may have heard about this study, and it's a study that really has had a tremendous impact on how the Black community in this country feels about the healthcare system. This was a study sponsored by the US Public Health Service. The goal of the study was to see what would happen if syphilis, which is a sexually transmitted disease, was left untreated. Okay, that was the whole point of the study. But the men who were enrolled, there were several hundred of them. They were uneducated men, unemployed. In exchange for lunch and pocket change, essentially, they were enrolled in this study, told that they had quote unquote bad blood, never told that they had syphilis. And even though there was a treatment for syphilis, which was penicillin, these men were never given penicillin. So what happened? Over time, these men developed secondary and tertiary syphilis, so more advanced syphilis. They ended up passing on syphilis to their female partners, and they even had babies with congenital syphilis. The study was stopped in 1972. And the reason it was stopped was because there was a Black epidemiologist at the CDC who found out about the study and was absolutely horrified, and broke the news and told the Associated Press. The Associated Press broke the news, and the US Public Health Service stopped the study. And so this is one of the landmark studies when we talk about Black communities' distrust of the healthcare system. This is one of the reasons why. And even when we talk about the coronavirus vaccine, there is a lot of vaccine hesitancy in our communities because of studies like this. And then here we are today, where we still have high rates of uninsurance in Black and Brown communities. We have the maternal mortality crisis that I mentioned, and we're in the midst of the COVID-19 crisis that has revealed these profound racial health inequities. And the inequities that we see today in this pandemic are related to availability of testing. It's related to the fact that these communities have a higher burden of chronic medical problems, and not because there's anything biological about it, but because they don't have access to care, because there are not healthy foods in their communities. Because of provider bias, we know it's been very well documented that clinicians have a preference for white patients over patients of color, and this comes out in practice. We've even seen it with the narcotic pain prescriptions. Clinicians are more likely to prescribe white patients pain medications than patients of color. As I mentioned earlier, it's also due to under-resourced healthcare institutions in these areas, as well as job exposures. Essentially, what systemic racism has done, it has essentially placed Black and Brown community members or limited opportunities in terms of what kind of work that they can do. And so they're in jobs that have increased exposure to being infected with COVID. And also the same can be said about housing as well as public transportation. And so what ties it all together is systemic racism. And so I want to just give you some definitions. Oppression is prejudice plus institutional power. Prejudice are our internally held biases, and power is the ability to decide what is best for someone who will have access to resources, so that's important to remember, and the ability to exercise control over others. And oppression creates systems, and systems that discriminate against some groups and benefits other groups. And so examples are what I've discussed: racism, but also sexism, ableism, classism, heterosexism, cissexism, homophobia, as well as transphobia. And so what's privilege? Privilege is a system that gives unearned advantages, favors, and benefits to some groups at the expense of others. I want to show you this diagram as an example. So on the left, you have a down escalator, and you have someone trying to walk up that down escalator. What happens? They're trying to walk up and the escalator is going down. In order for them to get to the top, they really have to bucket up those steps. They have to expend a lot of energy. The person on the right, there's an up escalator and they're walking up. And so they can still put some work in, but if they just stood still, they also could get to the top. All right, and so they don't have to work as hard as the person on the left, okay? And so that's another sort of illustration of oppression and privilege. I want to introduce you to this framework for thinking about systems of oppression like racism. I'm going to show you a video after this slide. It's about the 4 I's of oppression. One is ideological, which is oppression at the level of ideas. Institutional, oppression that's embedded at an institutional level, like healthcare. Interpersonal, which is what we think of more often, people disrespecting each other because of who they are. And then internalized, which is taking on those oppressive messages and internalizing them about yourself.
Oppression. It's a word that's often used as a blanket term, but there's actually a whole lot more to it. There are 4 interlocking aspects of oppression: ideological, institutional, interpersonal, and internalized. And it might seem like a small difference, but it's very important to be able to distinguish between each kind, because understanding oppression is the first step to fighting it. Let's start with the core at the heart of every form of oppression: ideology. Every system of oppression comes from the idea that one group is somehow better than another. Ideological oppression starts when the dominant group associates positive qualities with itself and negative qualities with the marginalized or othered group. Ideological oppression describes the deeply ingrained social root of inequality. It's the larger overarching idea that leads to the isms. For example, the idea that black people are dangerous is ideological racism. The idea that poor people are lazy is ideological classism. Ideological oppression leads to institutional oppression. Institutional oppression is the way that systems and institutions manifest the dominant ideology. Institutions control access, who is able to get to what and how. This includes legal rights, police practice, access to medical care and education, public policy, political power, and media representation. For example, when women make 2/3 of what men make, that's institutional sexism. When a building is constructed without wheelchair ramps, that's institutional ableism. All of this leads to interpersonal oppression. Interpersonal oppression is probably the easiest to recognize because it happens all around us. Interpersonal oppression is the way that people play out discrimination and violence on each other. It can take the form of microaggressions, jokes, stereotypes, and harassment. For example, when a student is bullied for being gay, it's interpersonal homophobia. When a Muslim person is told that they're a terrorist, it's interpersonal Islamophobia. And all those forces, ideological, institutional, and interpersonal, lead to internalized oppression. Internalized oppression is the way that people with marginalized identities internalize narratives of their own inferiority. It's what leads people to feel less than. This is the end goal of oppression. The oppressive party doesn't need to exert force any longer because the marginalized group is enacting oppression on itself to maintain the status quo. It's important to remember that it's never a marginalized person's fault that they feel internalized oppression. It's simply what happens when someone faces negative stereotypes, low expectations, and ongoing discrimination. So, for example, an immigrant feeling embarrassed about having an accent is internalized xenophobia. When a trans woman feels that they can never be a real woman, that's internalized transphobia. So, to review, the 4 I's of oppression are ideological, institutional, interpersonal, and internalized. Each of these types are interconnected and completely supported by the others. They can never exist on their own and can even be seen as a cycle. Now that you understand the different kinds of oppression, you're even more equipped to fight it. Don't forget that any effort to dismantle oppression should aim to address it at all 4 of these levels. Thanks for watching.
All right. So who knew that you could use Legos to explain systems of oppression? So I have a quick activity for you. In the following examples, I want you to select the primary type of oppression that applies to the example. So as the video explained, definitely are always different multiple types of oppressions are occurring at the same time, but I want you to choose the primary type. For example, if I tell you that Black women are 3 to 4 times more likely than white women to die from pregnancy-related complications, I want you to tell me what kind of oppression is that? Which of the 4 I's? Is it internalized, interpersonal, institutional, or ideological? Good, yes, institutional, very good. So that's the predominant type. And yes, it can definitely manifest as interpersonal and ideological, but the predominant type is institutional, very good. Okay, what about this one? The cultural narrative that white patients are more compliant and more likely to follow clinician instructions than Black patients and other patients of color. So what kind is that? Is that internalized, interpersonal, institutional, or ideological? Very good, you guys are getting it. Good, ideological, exactly. It's like this idea that you're believing one type of patient is better at something than another type of patient. So yes, ideological, perfect. Okay, what about this one? A Black child identifying a white doll as good and a Black doll as bad. What type of oppression is this? Very good, internalized, right? Because the Black child is internalizing these oppressive, toxic messages that Black is bad. Very good, so internalized. Okay, what about this one? Clinicians are less likely to prescribe pain medication to Black patients than to white patients. And by the way, these are all true and backed up by the literature and the data. So what kind of oppression is this one? Clinicians are less likely to prescribe pain medication to Black patients than to white patients. Yeah, so this one is actually, this is interpersonal. Yes, because it's essentially in their prescribing habits, who they're choosing to give pain medication to and not to, that it's at an interpersonal level. So yes, interpersonal, good. Very good. And so again, these are the 4 I's. I'm happy to take a screenshot of this or send a slide of this to the organizers if you are interested in this. But I also would like to hear from you. For those of you who this is like the first time hearing about the 4 I's, how do you think the 4 I's can help you to understand challenges in patients' lives as well as in their communities? What about so knowing about these levels or these different types of oppression you think could be helpful to making sure that like we deliver better care to them? Right, recognizing bias and correcting it, okay. Being aware, what else? Right, so more able to effectively find solutions. Yeah, absolutely, because you know the different levels, yes. So the different levels help you identify where the problems are, but they also help you to target solutions at those levels, right? Knowing that educational institutions, right, are one of those structures, absolutely. But this is not just about interpersonal, slights, but also about ideological. And yes, and very good, making structural change. So that's one thing I want you all to leave from here, is that it's not just changing your behavior, but changing how institutions and social structures work. Yes, same as with students. I don't have patients who are thinking about students. It reminds me that there are systems at play, not just behavior, exactly. Right, helps you to provide a more equitable approach. Yes, we can counter the racism we see others practicing, right? So framework, yes, so it gives you a framework for understanding the problems, but also the solutions. Yes, targeting interventions, yes. And I love this, being not racist is insufficient. Yeah, you actually have to work to, as the next person dismantled these issues within institutions, but at an ideological level, internalized level. Good, right? It helps you have language for discussion, which I often feel people just don't have the language for these conversations. And so I'm hoping this framework provided you with that. Great, thank you for your feedback. And so going back to structural competency, this idea of just thinking more broadly about how, right, these social structures influence health outcomes. And someone mentioned the same you can think about in terms of educational outcomes as well. So it's the same factors influencing those more downstream factors. And so I want to share with you, so the person in this picture is on the left is Dr. Mona Hanna Atisha, and some of you may know who she is. So she is a pediatrician who, from Flint, Michigan, who noticed when she drew her pediatric patients' blood work, so her patients are children, and she noticed they had very high levels, and she tried to write letters to her Congress people about this to make them aware of this problem, and no one responded. And so she ended up, not just thinking about the work that she does within her clinic, but she said, I have to make sure that I address this at a broader structural level. So she actually called a news conference and announced that she found this pattern in her the children's blood work, and she was worried about the water containing very high lead levels. And it was her as a physician, her press conference is what led to what we all know about the Flint, Michigan water crisis. But it just shows how when you think more broadly, not just about your interactions with patients or with students, but you think about more structural issues, how you can help be an advocate for them. And even the Black Panther survival programs, like they were very much ahead of their time in terms of thinking about structurally competent care. They had health clinics that offered free health care. They had free breakfast programs for children. They offered legal clinics for people to obtain legal advice. They offered transportation to prisons for loved ones. They even offered sickle cell testing. So all of these factors that are so important in the health of communities, the Black Panthers were thinking about this decades ago. And so even thinking about how in our current state, in the midst of this pandemic, how health centers can help, they can actually ensure that all of their patients have internet access, so they can work with broadband companies around this. They can work with housing and food advocacy groups to make sure that the communities aren't suffering from food and housing insecurity. They can help deliver resources like personal protective equipment, like masks and gloves, and they can even help with rental issues and labor concerns and immigration issues. So healthcare institutions don't just have to deal with health, because we know that, as I demonstrated to you, there are all these other factors that influence the health of communities. And so these are some other levels of intervention that you can think about. You can think about how you're going to intervene on an individual level, interpersonal level, within an institution. You can think about how whatever institution you're affiliated with, how do they interact with communities? How do they engage with the community? Do they center the communities that they exist in? Do you know the priorities and the concerns of those communities? And what about research and policy? How can you use research and policy to look at these larger structural issues like social and economic policies, like systemic racism, right? Because we know that at a community research and policy level, that's how we can have the largest influence on helping support communities. So I'm just curious from you all, if you can just share with me, like, which level of intervention do you think that you can make a difference in terms of, I know that you all are at different stages of your lives, but if you can just share, like, which level do you think that you would want to make a difference on? Good. So I'm glad to see all of these levels, because it's all really important. I want you all just to think also more broadly. I think interpersonal is great, but I think I want you to think more about societal context, about how you can work with institutions, communities, and even on a policy level. Like, you can write editorials, you can do advocacy work, and so it really can help make a difference in people's lives and the health outcomes of communities. So thank you for sharing these. And so my take-home points for you all, and thank you so much for your engagement, is that I want you to understand that it's systemic racism that is a risk factor for disease. And so when we talk about certain communities like Black and Brown communities having higher rates of diabetes, high blood pressure, and COVID, it's not because they did anything wrong. It's because we have these practices and policies that have been set up that have disadvantaged and essentially disinvested in communities and in people. And essentially it's made them sick. And so that when you have a pandemic that hits, the most vulnerable people get affected. I want you to think about structural competency, about this idea of thinking more broadly about social structures and how they impact health outcomes. And then obviously the last part is to be intentional about mobilizing for health equity. So if this is an area of interest to you, definitely remember all of those levels that you can make, where you can make a difference. And so I'm done. Questions, anybody?
That was fantastic. Thank you so much. I think a lot of the questions that came in, you kind of addressed at the end of like these take homes of what we can actually do. But one that pertains specifically to this conference is, so in the spirit of the conference, how can scientists communicate truths to the public? So is there a role of science communication in this, and what is it? What can we do?
Yeah, no, I think that's such a great question. And even in the beginning, in my intro, you mentioned that even I had been doing a lot of media work, and I had no interest in doing media work, but what I saw in this pandemic, and I was very concerned about the misinformation that was out there. I was also, and that was being conveyed by this administration, but also I wanted to make sure I had the opportunity to amplify some of the issues I talked about in the talk today. Like I want people to understand how upsetting and horrifying that we're seeing these racial health inequities. And so I do think that there is so much advocacy in health and scientific communication. Like you really can ensure that the public is getting accurate and responsible information. And I don't think there's anything more powerful than that.
Great. And along those lines, several of the participants asked if you would be willing to share your slides.
So there are certain slides I will share. I can't share the whole slide deck because it's my intellectual property, but I can share like the 4 eyes of oppression, the different levels of intervention, the pyramid with socioeconomic factors. Yeah. So there are a few of the key slides, and I know what they are. I'm happy to share them.
Perfect. That would be wonderful. And then one last question, because I know we have to get ready for the next event. In terms of confounding, how do we look at racism rather than self-defined race to see the impact? Wait, hold on. To see the impact on health outcomes.
I don't know if I understand that question. So can you read it again?
So how do we look at racism rather than self-defined race to see the impact on health outcomes?
Yeah, I mean, no, so that's a great question. I mean, I think that what's really important is when we have data, is that we have to disaggregate it by race. And then we have to look and see like what is going on in these communities. And trust me, there are epidemiologists and public health experts that have already done this work for us. But what we see is lack of access to jobs. We see to gainful employment. We see overcrowded housing. We see people being forced to take public transportation. So we're seeing all of these factors that not only are additive, but they compound each other and essentially place these communities at risk.
Great. So there are a few other questions, but just to make sure I give people a break, I think I'll stop here. But okay. Is there a way that people could ask you these questions? Should it be on Twitter? Or...
Yeah, you can ask me on Twitter. You can just tag me. On Twitter, and I will answer questions. Yeah.
Excellent. All right. Thank you so much. This was incredibly informative.
Thank you, everybody.
Yeah.
Thank you so much.